Hello, everyone, and welcome to our module on the rule of fours. So the rule of fours is a handy mnemonic that you can use to localize a brainstem lesion. So when a patient presents with a stroke involving the brainstem, they have various clinical features. You need to use those clinical features to determine whether the stroke is in the midbrain, the pons, or the medulla, and whether it's medial or lateral, and that's what the rule of fours can help with. The rule of fours was developed by Dr. Peter Gates. He published this article I've referenced at the bottom of the screen in 2005. And it's actually a very short paper, just a couple of pages, and I highly recommend reading it if you're going to be studying neuroscience and you're going to need to use the rule of fours to localize brainstem lesions. So basically, the way the rule of fours works is that you take the patient's clinical presentation and you determine what tracts are affected, meaning corticospinal tract, the corticobulbar tract, the spinothalamic tract, and then you also determine which cranial nerves are affected. And so you use the tracts to determine whether the lesion is medial or lateral, and then you use the cranial nerves to determine whether the lesion is in the medulla, pons, or midbrain. You can think of the brainstem like an axis, like I've shown here, and the tracts involved tell you whether the lesion is lateral or medial, and the cranial nerves that are involved tell you whether the lesion is in the midbrain, the pons, or the medulla. So shown on this slide are the elements of the rule of fours, and let's go through them one at a time. So according to the rule of fours, there are 4 cranial nerves in 3 locations, 4 above the pons, 4 in the pons, and 4 in the medulla. And I'll talk about this in more detail in just a minute. On this slide, I'm just giving you the broad overview. The rule of fours also says there are 4 cranial nerves that divide evenly into the number 12. Those are cranial nerves 3, 4, 6, and 12, and they all have motor nuclei that are midline or medial. The rule of fours also says there are 4 cranial nerves that do not divide evenly into 12. Those are cranial nerves 5, 7, 9, and 11, and they all are laterally located in the brainstem. Then the rule of fours says there are 4 midline columns or pathways. They all begin with the letter M. These 4 columns are the motor nucleus, the motor pathway, the MLF, and the medial lemniscus. And I'll talk about what I mean by all these things in a second. And then finally, the rule of fours says there are 4 lateral or side columns. They all start with the letter S for side. These are the sympathetic column, the spinothalamic column, the sensory and spinocerebellar columns. And so broadly speaking, this is the rule of fours mnemonic shown right here. You can see that all of these things are easy to remember because they have the number 4 involved. And also in terms of the tracts or columns, the midline ones start with the letter M and the side or lateral ones start with the letter S. Okay, so the rule of fours says there are 4 cranial nerves above the pons. What does this mean? Well, the 4 cranial nerves located above the pons are cranial nerves 1, 2, 3, and 4. Now, cranial nerves 1 and 2 are not in the midbrain or the brainstem, so they're not relevant to localizing brainstem strokes. But cranial nerve 3 is found in the brainstem. It's found above the pons in the midbrain. And so if you see an oculomotor nerve lesion, which is when the eye is turned down and out on one side, this localizes a brainstem lesion to the level of the midbrain. The same is true for the trochlear nerve, cranial nerve 4. A lesion of this nerve causes the eye to be unable to look down when looking inward towards the nose, towards the midline. So a lesion here also localizes a brainstem lesion to above the pons, meaning in the midbrain. Then there are 4 cranial nerves in the pons. Those are cranial nerves 5, 6, 7, and 8. So a lesion of the trigeminal nerve, cranial nerve 5, causes ipsilateral facial sensory loss. So if you see this, it localizes a brainstem lesion to the pons. Same for a lesion of cranial nerve 6, ipsilateral eye abduction being weak. Same for a lesion of cranial nerve 7, ipsilateral facial weakness or droop. And same for a lesion of cranial nerve 8, ipsilateral deafness. Any of these findings here, which indicates a lesion of these cranial nerves, is going to localize a brainstem lesion to the pons according to the rule of fours. And then finally, the rule of fours says there are 4 cranial nerves in the medulla. Those are cranial nerves 9, 10, 11, and 12. So for example, if you have a lesion of cranial nerve 9, the patient will present with ipsilateral pharyngeal sensory loss. That localizes a brainstem lesion to the medulla. Same for a lesion of cranial nerve 10, that will create ipsilateral palatal weakness. Same for cranial nerve 11, that will cause ipsilateral shoulder weakness. And finally, if you have a lesion of cranial nerve 12, you get weakness of the tongue. So any of these deficits here, which indicate a lesion of any of these cranial nerves, according to the rule of fours, that localizes the lesion to the level of the medulla in the brainstem. Okay, and then according to the rule of fours, there are 4 midline structures that all begin with the letter M. Damage to these structures is going to indicate that a lesion is midline or medial in the brainstem. So what are the 4 structures that begin with the letter M? First one is the motor pathway. This refers to the corticospinal tract. So damage here leads to contralateral weakness, and according to the rule of fours, that localizes a lesion to the medial section of the brainstem. The medial lemniscus is another midline structure that begins with M. Damage here leads to loss of contralateral proprioception or vibration. This also localizes a lesion according to the rule of fours to the midline. The medial longitudinal fasciculus is important for lateral gaze. If you have damage here, you get an ipsilateral intranuclear ophthalmoplegia, which is an eye condition I talk about in the ophthalmology section. And then finally, the final M is motor nucleus and nerve. This refers to cranial nerves that have midline nuclei. And remember, those are the ones that are divisible by 12. Those are medial. So lesions involving cranial nerves 3, 4, 6, or 12, these are all motor nucleus and nerve lesions that localize, according to the rule of fours, a brainstem lesion to the midline. And then lastly, we have four side or lateral structures. They all begin with the letter S. These localize lesions to the lateral portion of the brainstem. So the first one is the spinocerebellar pathway. Damage here causes ipsilateral ataxia. Spinothalamic tract damage causes contralateral pain and temperature sensory loss. The sensory nucleus of cranial nerve 5, the trigeminal nerve, damage here causes ipsilateral pain and temperature loss in the face. And then finally, the sympathetic pathway refers to sympathetic nerve fibers. They run laterally in the brainstem. So damage here indicates a side or lateral lesion. And clinically, this will present as an ipsilateral Horner syndrome. And so here's my own little drawing tying together the blood supply to the brainstem and the rule of fours. So over here on the right, we've got the brainstem. This is the midbrain, this is the pons, and this is the medulla. And shown in numbers here are the cranial nerves. The ones that divide into 12 are all medial right here. The ones that don't divide into 12 are all lateral out here. And then shown over here on the left side is the blood supply to the brainstem. So the midbrain's blood supply is entirely through the PCA, both the medial and lateral portions. So if you use the rule of fours and you localize a lesion to anywhere in the midbrain, medial or lateral, the PCA is going to be the vessel involved in the stroke that led to that lesion. In the pons, the lateral blood supply is through the AICA and the medial blood supply is through branches of the basilar artery. So here, when you localize a lesion to the pons, if it's medial, then it could be caused by a stroke involving branches of the basilar artery. A lateral pons lesion is going to be related to the AICA. And then down here, we've got the medulla. The lateral portion is supplied by the PICA, the medial portion by the anterior spinal artery. So this slide right here is my way of tying together the rule of fours for localizing brainstem lesions over here to the blood supply so that if you see a lesion described and they ask you stroke involving what vessel caused it, you can use this drawing on the slide here to figure that out. All right, so the easiest way to understand the rule of fours is to just go through a couple of examples where we use it together so you can understand how to apply it. So let's start by talking about case one. A 75-year-old man has weakness. 2 hours ago, he suddenly became unable to move his left arm or leg. He has no problems with speech. All facial muscles move normally. There's no ophthalmoplegia. When he protrudes his tongue, the tongue is deviated to the right. He also can't detect upper and lower extremity vibration on the left side. So in this slide, I've broken that case down into the elements you need to identify to apply the rule of fours. So first of all, the patient has complete left-sided motor weakness. Importantly, he has no cortical signs like aphasia or spatial neglect, so you know that this stroke is not in the cortex. He also has dense hemiparesis. His face, arms, and legs are all affected equally. They don't describe any differential effects that are greater in one region than the other. That's dense hemiparesis. And that's also what you see in brainstem strokes. That's not what you see in cortical strokes. So because of these two things here, right away when I read that case, I know this is not an MCA or ACA stroke. Also, he's got motor weakness. That's one of the M's. And so we know according to the rule of four, that makes this a medial lesion in the brainstem. He also has tongue involvement. That's cranial nerve 12. Cranial nerve 12 divides evenly into the number 12. So therefore, it is a midline lesion. And we already knew that this was a medial lesion, but now we know it even more from cranial nerve 12 being involved. And then cranial nerve 12 is one of the four cranial nerves in the medulla. And he has right deviation of the tongue. So the tongue always deviates toward the side of a lesion with a cranial nerve 12 lesion. So he has a right-sided lesion. So based on this information here, all of which comes from the rule of fours, I can figure out that this is a right medial medullary syndrome. And then according to that slide I showed you 2 slides ago, the blood supply to the medial medulla is the anterior spinal artery. And so if I was asked which vessel is most likely involved in a stroke for this patient, the answer would be the ASA. Okay, let's do another case. For simplicity's sake, I won't write it out like a long stem. I'll just give you the key features and we'll go through them together. So imagine someone presents with dense right-sided weakness and the left eye is down and out and the pupil is dilated. Okay, so let's break it down. This man has right-sided motor weakness. Motor weakness starts with an M. It's part of the motor pathway, so this means it's a medial lesion. Also notice that I described dense or complete motor loss. So this means that this is not a cortical stroke. It's in the brainstem. It's not a stroke of the MCA or ACA affecting the cortex. Question also describes the left eye being down and out and dilated. This is a cranial nerve 3 lesion. Cranial nerve 3 is one of the 4 cranial nerves found above the pons in the midbrain. So this is a midbrain lesion. And also cranial nerve 3 is divisible evenly by 12, so we know it's a medial lesion. So this man has a left medial midbrain lesion. And the clinical syndrome that causes left medial midbrain problems is Weber syndrome, which I talk about in the brainstem video. And it's caused by ischemia in the blood supply to the midbrain, which is all through the posterior cerebral artery. So a stroke of this vessel could have caused this presentation. Okay, let's do a third case. So once again, for simplicity, I'll just give you the highlights. So imagine the patient has abnormal left hand finger to nose testing. There's a loss of pain and temperature sensation to the face. The left eyelid is drooping and the pupil is constricted or small. There's a loss of pain and temperature sensation in the right arm and leg. The voice is hoarse. The gag reflex is lost and the palate is raised on the right side. So on this slide, I've converted all those bullets to the features you have to identify to apply the rule of 4s. So abnormal left-sided finger-to-nose testing indicates ataxia. So this man has left-sided ataxia. Loss of pain and temperature sensation to the left face means there's damage to the left cranial nerve 5. The eyelid drooping and the small pupil, that's Horner syndrome, also on the left side. And the loss of pain and temperature sensation in the right arm and leg means there is a lesion of the left spinothalamic tract. And then we've got some cranial nerve involvement. Hoarse voice means cranial nerve 10 is involved. Loss of the gag reflex on the left side of the throat means cranial nerve 9 is involved. And the palate being raised on the right side, that also indicates cranial nerve 10. So now that I've done all this, I can use the rule of 4s to figure out where the lesion must be. So the left-sided ataxia means the spinocerebellar tract is involved. This is a side pathway. It means the lesion is lateral on the left side. Left pain and temperature loss to the face means cranial nerve 5. 5 is not divisible evenly into 12, so this also tells you it's a lateral lesion. The Horner syndrome on the left side means the sympathetic pathways are involved. That's a side pathway, and therefore that's another indication of a lateral lesion. And then we have right-sided pain and temperature loss, which means there's a left spinothalamic tract lesion. Spinothalamic tract is another S or side pathway, so this also tells us it's a lateral lesion. So we have all this evidence of a lateral lesion. What we need to know now is what level of the brainstem is it at. And so he has problems with speaking, the gag reflex, palate problems. These indicate damage to cranial nerves 9 and 10, and those are all medullary cranial nerves. So now we have all the information according to the rule of 4s to identify that this is a stroke or a lesion involving the left lateral medulla. That's called Wallenberg syndrome, and it indicates a stroke of the posterior inferior cerebellar artery. Okay, and then I'll do one final case. Imagine that we have right-sided deafness and tinnitus. We've lost the right-sided finger-to-nose testing. There's facial numbness on the right. Corneal reflex is gone, and there are spasms on the right side of the face. So the deafness and tinnitus means cranial nerve 8 is involved on the right. The ataxia, which is the loss of the finger-to-nose testing, means the spinocerebellar tract on the right is affected. Facial numbness means you've got sensory loss on the right. Corneal reflex involves cranial nerve 5. The facial spasms indicate involvement of cranial nerve 7. And so we have all these S pathways like spinocerebellar and sensory. So we know this is going to be a lateral lesion. We know it's on the right side because of the right-sided findings like deafness and tinnitus. And then we've got cranial nerves 5 and 7 involved. Those are cranial nerves of the pons. So now we know that this is a right lateral pontine lesion. And this is the kind of lesion you can get with something going wrong at the cerebellopontine angle, which I talk about in the video on the cranial nerves. This is often caused by tumors like schwannomas. But once again, applying the rule of 4s, converting the clinical findings of the patient into problems in the brainstem, and then using the rule of 4s to tell you what level of the brainstem you're at and whether you're medial or lateral. That solves this case and gives you the answer. Okay, so I'll finish with this slide here, which basically summarizes everything we've talked about. Remember the 4 side pathways that tell you a lesion is lateral, the 4 M pathways that tell you a lesion is midline or medial. And we've got all the cranial nerves shown here, the ones in the midbrain, the pons, and the medulla. The ones that divide evenly into 12 are medial. The ones that don't divide evenly into 12 are lateral. You can use this to answer lots of questions about localization of brainstem strokes. And I highly recommend now you go and do the practice questions associated with this video. They can all be answered using the rule of 4s, and that will get you used to applying it. And that concludes our module on the rule of fours.